Welcome to today's episode of The Science Pitch, where we delve into new avenues to combat diseases that are prevalent in our society. Most prostate cancer therapies focus on targeting primary tumors, however, it is metastasis that is the main cause of death. Currently, there is a lack of treatment that prevents a progression of stage 3 to stage 4 in prostate cancer. To fill in this gap, we are proposing our new drug R4L12.
Cellular signaling mechanisms are often hijacked by prostate cancer cells to cause migration from the prostate to the bone. CXCR4 is a chemokine receptor that is significantly expressed on the surface of malignant prostate cancer cells in comparison to that of benign prostate tissue. When the receptor is overexpressed, this causes an exaggerated interaction with CXCL12. CXCL12 is a chemokine that binds to CXCR4, and it can be the root cause for metastasis and trouble in our body.
Areas within the body that upregulate CXCL12, like the bone, act as a chemoattractant. CXCL12 is preferentially expressed by osteoclasts in the bone and during prostate cancer cell exposure. CXCR4 and CXCL12 interact to stimulate a signaling cascade. This activates the PIK, AKT, and MAP kinase pathway, resulting in the production of matrix metalloproteases. MMPs like MMP9 are secreted by cancer cells to assist in their migration and invasion into non-malignant environments as they work to degrade the basement membrane of healthy cells and invade to the bone.
Our therapeutic treatment will involve antibody antagonists that will bind to and block CXCR4, stopping CXCL12 from binding to its receptor. This will inhibit downstream signaling events that promote the metastasis of the cancer cells and consequently prevent the release of MMPs. As a result, the cancer will not be able to use MMPs to break the extracellular matrix and invade the underlying stroma. The therapy will specifically use monoclonal antibodies, which naturally have high affinity and avidity for their target.
Our approach is revolutionary because we will be using a fusion protein technique which we believe hasn't been tried on patients with prostate cancer. The monoclonal antibody itself will be bound to the cytokine fragment. We will be using interleukin-12, which is a central mediator of innate and cellular immunity. This particular cytokine will be responsible for the recruitment of various immune cells directly to the site of the tumor. This treatment will attempt to boost the host immunity in the proximity of the cancer and further inhibiting its spread.
Our preclinical trials of R4L12 can be carried out by patient-derived xenograft mice models. PDX mice are immunodeficient, or also known as SCID mice, to avoid tumor rejection. We extract prostate cancer cells from human patients and inject them subcutaneously in the subrenal capsule region, just under the surface of the kidney, as it has been shown to have high vascularization and lymphatic flow. The tumors can be monitored and maintained in vivo for several weeks. R4L12 will be injected intravenously after tumor growth. The advantage of using a PDX model is that the tumors grow and remain biologically stable, enabling tumor growth that closely mimics the human tumor.
There have been studies done to investigate the use of monoclonal antibodies in the treatment of prostate cancer. Mice treated with DNA-encoded antibodies showed significant reduction in tumor lesions 56 days after administration, as well as increased survival rates compared to the negative control group.
So, in the scope of things, R4L12 hopes to contribute to the therapeutic index of anti-cancer treatments. The antibodies have a long half-life, eliminating the need for repetitive injections. By combining targeted therapy and immunotherapy, the drug aims to contain metastasis, preventing cancer recurrence after surgically removing tumors. Its high specificity and fusion of interleukins stimulate the patient's immune system only within the localized area of the tumor, hence evading the hypoxia-induced inflammation in untargeted tissue.
Production cost is posed as one of our limitations. Most monoclonal antibodies are large in size, so large cultures of mammalian cells are needed, followed by rigorous purification steps. Due to its size, the antibodies may not be able to fully penetrate the targeted tissues. It should also be noted that most chemokines also utilize the CXCL12-CXCR4 pathway to guide the movement of leukocytes to target tissues. R4L12 may hinder the movement of endogenous leukocytes, impeding on the patient's own immune function. Although preclinical trials have only been used in mice with toxicities that are low and warranted, it may not clearly foresee the complete pathological spectrum in humans. However, our drug represents a support in developing a new approach in preventing malignancies in prostate cancer.